Morning. I'm Dan Picus, and I'm the chair of the CPT Coding and Nomenclature Committee, and I'm going to talk for just a few minutes about a couple things which we've talked about before, bundling and the multiple procedure payment reduction. So similar to last year, the college has been busy at the CPT editorial panel. That's our primary responsibility. A number of new codes, deleted code, revised code, but the bottom line is the majority of our work, the majority of what we do at CPT now is related to the mandate to bundle codes. And so the majority of the codes that we've come out with in the current cycle are bundled codes. So what's up with all the bundling? And we've heard about that already today and yesterday, but bundling versus component coding is unfortunately become pretty much a constant discussion point for us. Component coding is how we code in radiology. It's not just interventional radiology procedures, it's how we code in CT, MR, ultrasound, nuclear medicine, and even in the plain film area. Bundled codes component coding is basically how we report our services. Component coding is good, and we try and explain this to people, but component coding really allows us, it's a very novel way, a very good way, accurately describing all the complex services we provide as radiologists with a very small code set. And it allows data also to be accumulated in a health services way to tell exactly the services we perform. However, outside of radiology, all of our component codes are viewed as ways to game the system. And when we go and talk to colleagues that use E&M coding, they'll say, look at those 10 codes you just used to report that carotid arteriogram, and all I get is a single code for my evaluation and management visit. That doesn't seem fair. And it's made a very large target for us with regards to reimbursement and coding. I will add that many of us have, many specialties have been affected, cardiology as well, but radiology has been affected in a way that others have not. It's just a list of some of the mandated, potentially valued, misvalued services, and bundling codes is really a key perceived way of sort of evening the playing field. In response to a lot of different pressures, a CPT RUC work group was established about 5 years ago now to look for opportunities for savings when codes were reported frequently together. Among other things, and this has evolved into something you may have heard of, which is called the RAW, the Relativity Assessment Work Group. And the job of this work group, which is a joint CPT RUC work group made up of many individuals, we do have representation on that work group, but it's mostly it's all non-radiologists, is to really look for areas where there are opportunities to make relativity assessment between codes, between services, more fair, if you will. So they developed a screen, and we talked about this last year. The screen was a 95% screen, looking for codes that were used together 95% or more of the time. And it's really difficult to go out and talk. It doesn't really pass the sniff test to say that a code that's used with another code 95% of the time really needs to stay separate. And so that level was pretty easy to work with, pretty difficult to argue against, and it led to a large number of bundled codes. Some of these are history now. The CT abdomen pelvis was a huge issue for us, and that was a new code a year ago, along with lower extremity revascularization. Just again to show that it wasn't just radiology, the entire cardiac catheterization code set. So if many of you have friends who are cardiologists, I'm sure you've heard them complaining of how badly they were mistreated by this process because their entire code family was used together more than 95% of the time and had to be revalued. More bundled codes are on the way. A few were introduced a couple months ago. CTA, abdomen, pelvis, renal angiography, IVC filter, but the big ones are going to be January of next year, where cerebral angiography, all of the cerebral angiography codes are going to be bundled, and a few others. And for interventional radiologists, one that we're just beginning to work on are the embolization codes, which have been mandated to be bundled, and the deadline for that is January 2014. The 95% screen was so successful that a new screen was developed, a 75% screen, And if you thought there were a large number of codes on the 95% screen, the number of codes on the 75% screen is just huge. In radiology, a large number of codes, the MRA of the head and neck, breast procedures, abscess drainages, myelography, biliary and GU procedures, and even hip x-rays found their way onto the 75% screen. And it's still not clear. We're still working through how we're going to address all of these new code pairs that were identified. Obviously, there's a significant impact to reimbursement when codes are bundled. The entire family has to go back to the RUC. Zeke will talk a little bit about that, but you never come back intact after you go to the RUC. It's always a painful experience. Generally viewed that component coding is not a viable model. We've not been able to get any component codes through CPT in the last number of years, and there's a large number of unintended consequences here, leading to complex coding scenarios, and loss of ability to track individual services, not to mention the reimbursement issues. I want to spend the second part of my talk talking about the MPPR. We've heard about that a number of times now in different venues, and I'm just going to try and highlight a couple unique issues with the MPPR. I don't have any answers, but just to point out some of the problems and some of the things we're dealing with. For those of you that don't know, it's the Multiple Procedure Payment Reduction, MPPR. We've been familiar with an MPPR for the technical component for several years now, for a handful of years, where the technical components reduce 50%, and that's something that we've sort of gotten used to. But the MPPR for professional service is a new thing, thing to contend with. And it sort of started a long time ago, but in June of 2011, MedPAC recommended this as a way to extend efficiencies to professional services. There was a proposal in the final rule. We've heard about that now, where it was a 50% reduction for advanced imaging services for the same patient, the same day, the same session, and the same group practice. Fortunately, through a lot of hard work on the college's part and other people's part, the final rule was a little less stringent. It's a 25% reduction for second and subsequent services on the professional side for the same patient, the same interpreting physician, and the same session. There's a number of points of confusion and contention here with this MPPR on the professional side, and we've heard a few of those, and we're going to talk about a few more. What's clear is that CMS didn't really use any kind of hard data to support this concept of a significant physician work efficiency when services are provided together. The efficiencies would have to be, if you think about it, in the pre- and post-service work, because the intra-service work is really additive when you do multiple studies at the same time. And there is probably a tiny bit of efficiency here, but a nice article. If you haven't read it already, you might want to just look through it. It was in the Journal of the American College of Radiology by Bibb and a number of other colleagues in the ACR, showed that this efficiency was really on the order of 3, 4, 5%, depending on the modality and the code pair, clearly not the 25% that was mandated. We have no idea what CMS means by a session. A session is really not defined in the final rule. A session is really not clear. What is clear is that a session is different on the technical side and the professional side. A technical session is a little bit easier to understand. It's when the studies are performed. But the rule for what a professional session is when the studies are interpreted. And you can quickly see why those are different and very confusing when you try and mash them together. Unlike the technical component, the professional component MPPR can cross modalities. And this is from the final rule, CMS saying, we recognize that in some cases imaging tests utilizing different modalities may be conducted in different sessions for the technical service, such as when a patient may be moved to a different floor. But on the professional side, such cases may or may not be furnished in separate sessions. Chaos, very confusing. CMS's only guidance on the separate session issue in the final rule was that scans interpreted at widely different times would constitute different sessions. There's no definition or guidance on what widely means in the final rule. The issue of same physician, and that was something that was quite concerning when it was going to be applied to group practices. I think this still impacts smaller groups in particular with the same physician rule. Due to operational considerations, CMS did not apply the professional component MPPR to group practices at this time. They're obviously leaving the door open to doing it later. But if the studies are interpreted by different physicians, even in the same group practice, the MPPR does not apply. It doesn't take a whole lot of thinking to figure out how this might work. CMS goes on to say that it would be considered inappropriate if physicians were assigned different studies to read to bypass the MPPR. You can take that for what you will. The use of the 59 modifier. For those of you that don't know, the 59 modifier is used in CPT to define different sessions, if you will. And so CMS has instructed us at this point to use the 59 modifier if the MPPR on the professional component does not apply. And that would bypass the professional component MPPR. CMS says that we recognize that it may not always be a simple matter, to determine whether services were furnished in the same session. The physician will need to exercise judgment to determine when it is appropriate to apply a 59 modifier. And then they go on to say, of course, we do not expect the use of the 59 modifier to be a frequent occurrence. Thank you. Use of the 59 modifier inherently conflicts with the CCI edit guidelines. And we've been for a very long time using the 59 modifier to bypass CCI edits. And so it's not clear at all how this 59 modifier that's used to bypass the professional component MPPR is also going to use to bypass CCI edits that are justifiably need to be bypassed. And so there's certainly times when those are going to conflict, and it's very confusing at this point how to do that reliably and in good faith. So what's a radiologist to do? Well, here's a couple examples that we've come up with where the MPPR should be applied. A head CT and a cervical spine done at the same time, interpreted at the same time. Clearly that's the intent of the MPPR, and a 59 modifier would not be appropriate. MPPR not applied, an abdominal CT obtained and interpreted in the morning, and then an abdominal ultrasound performed and interpreted by the same physician that same afternoon. Separate sessions of interpretation. This is sort of the ACR's opinion of widely different times, and it would be appropriate to apply a 59 modifier since the service is performed on the same day. The ACR is working on putting together a series of similar vignettes that sort of bring up issues, bring up real-life examples of what a radiologist does and how should we apply this MPPR rule to these. We're going to submit them to CMS and ask them to give us some feedback and say, are we right or are we wrong? It's not clear what CMS is going to respond. I think personally that it's purposefully gray, but we'll see how that turns out. We're also looking for legislative relief, as we've talked about in this session and other sessions, and we'll see how that goes as well. So radiology is clearly facing many challenges with regard to coding and reimbursement in the old model, and we really need to remain involved and engaged to try and work as hard as we can to keep this current system going while we're working on setting up a new model and a changing system.